A 35-year-old female presents to the ED with breathlessness for the past 4 days, associated with central chest pain. She uses combined oral contraceptive pills, and her mother has a history of having clots in her legs. Because she's complaining of both breathlessness and pain, we'll use our OD paramnemonic for the breathlessness and OPQRST for the pain. This approach will help you cover all components of the complaint, so the onset, duration, intensity, progression, aggravating and relieving factors of the breathlessness, and the onset, precipitating factors, quality, radiation, severity, and timing of the pain. Before you move on from your history taking, remember to quickly run through your differential diagnoses. So with any breathlessness or shortness of breath and chest pain, you should think about pneumonia, ask about any recent coughs or fevers, pneumothorax, ask about any recent chest trauma, dissecting AAA. This would have already been covered in the pain part of the history taking, but this will remind you again, if you've missed it, to ask about the nature of the pain, whether the pain radiates to the back, as that's quite typical of dissection, as well as the pain being very severe, of course. And then MI, remember to ask about the common associated symptoms, such as sweating, palpitations, and shooting pain down the arm. Finally, before moving on to physical exam, ask the patient about her past medical history, medications, family history, and social history. This part will give you valuable information about PE risk factors. Take the vitals and examine the chest, so the heart and lungs, and also examine the legs. You're looking for any evidence of DVT, which would be any swelling, warmth, or pain in the calves. Always avoid using medical jargon with patients, so instead of saying pulmonary embolism, say that you're most likely suspecting a clot in the lungs that may have travelled from the leg. Also explain the risk factors that may have led to this. Family members who have had PE, any personal history of DVT, long periods of immobility such as recent surgeries or long flights, and certain medications like combined oral contraceptive pills. This can be potentially fatal if left untreated, so your plan should be to admit and to give supplemental oxygen if the sats are low. Order a chest x-ray, an ECG, and do an ABG. And your gold standard diagnostic test for PE is CTPA. You won't get marked down for this, but you can add D-dimer to your routine bloods if you want. However, D-dimer is not actually that useful in real life, because although it's a very sensitive test, it's also very non-specific, and it won't really guide or change your management in any way. And lastly, start the patient on a therapeutic dose of low molecular weight heparin, even before you've confirmed the diagnosis.